Welcome, everyone. I'm Dr. John White, and I want to welcome you back to the afternoon session of the 2022 Virginia Patient Safety Summit. So hopefully you're all getting a snack or something to eat and ready for a very interesting discussion. As I said, my name is Dr. John White, and in addition to serving as the Chief Medical Officer at WebMD and Medscape, I'm a member of the Medical Society of Virginia's Political Action Committee's Board of Directors. I'm also a board-certified internist. I continue to see patients in Northern Virginia. And before we start, I do want to take a moment to thank the clinicians and the healthcare workers who are attending today's summit, who have made quality, safe patient care a priority, even in the most uncertain and turbulent times. As we begin the third year, can you believe that, of the COVID pandemic that has essentially halted American society, we must take time to care for ourselves. We have to make it a priority to prioritize provider well-being and mental health, and to ensure our healthcare workforce is strong and capable of what's going to come in the months and years ahead. Now, I mentioned Medscape. We did a 2022 physician burnout and depression report. We do it every year. We survey over 13,000 physicians. And we really saw the gripping toll that COVID has had and continues to have on the profession. As you know, burnout has continued to increase as the impact of the pandemic remains an active part of our daily lives. In 2021, last year, 42% of physicians surveyed reported they were burned out. This year, 47%. 76% of physicians said their burnout had moderate to severe impact on their daily lives. It's because of these statistics and what I've learned through this research that I know we must take new and innovative action to address this crisis. Actions such as the Medical Society of Virginia's legally protected Safe Haven program. I'm proud to be part of MSV and support the Safe Haven program. When you think about it, MSV, Medical Society of Virginia, was the first state in the nation to provide legal protections to clinicians who seek help for their professional burnout without fear of negative professional repercussions. MSV has also worked with many state medical societies to get the Safe Haven model state legislation passed across the country. I encourage you to check it out. Learn more by visiting www.safehavenhealth.org. It's through national collaboration of all in healthcare environment that true action and results will occur. And ultimately, lives will be saved. So thank you for allowing me to share that. Now, it is my distinct pleasure to introduce our first keynote speaker. Dr. Joseph Betancourt is the Senior Vice President, Equity and Community Health of Massachusetts General Hospital, the founder, senior advisor, and faculty of the Disparities Solution Center at MGH, faculty at Mongan Institute, an associate professor of medicine at Harvard Medical School, and also a practicing internal medicine physician. He's also served on the leadership team of the MGH Center for Diversity and Inclusion. Dr. Betancourt is a nationally and internationally recognized expert in health policy, healthcare disparities, diversity, and cross-cultural medicine, and has served on several Institute of Medicine committees, including those that produce the landmark reports on equal treatment and increasing diversity in the healthcare workforce. Dr. Betancourt received his Bachelor of Science from the University of Maryland, his medical degree from Rutgers, New Jersey Medical School, and completed his residency in internal medicine at the New York Hospital Cornell Medical Center. Following residency, he completed the Commonwealth Fund Harvard University Fellowship in Minority Health Policy and received his Master's in Public Health from the Harvard School of Public Health. Now, we will have time for one or two questions at the end of the presentation, so please feel free to put your questions in the Q&A box. And with that, I'm delighted to introduce Dr. Betancourt.
Thank you so much, Dr. White. I really appreciate your kind introduction and thankful for this opportunity to yet again be able to humbly share some thoughts and perspectives that I hope will be valuable to the Virginia Hospital and Healthcare Association and to be part of this Patient Safety Summit. You know, the title of this year's summit, Resilience, the Cornerstone of Virginia Healthcare, is something that has deep meaning to me, and I'll get a chance to share more about why in a few moments. But it's my pleasure and honor to be with you here today. I'll make some comments, hopefully have an opportunity for questions, encourage you all please to share and to type your questions in so that we could make this discussion. I'm going to go ahead and share my screen now and provide an overview of the journey I hope to take us on in the brief time we have together here today. But let me just say a bit about what I do and why I do it, and then I'll jump into today's journey. So as Dr. White mentioned, I'm first and foremost a practicing internist. I spend 25% of my time seeing patients in the primary care setting. I've been here at Mass General Hospital for about 20 years now. I'm excited to have been able to dedicate my career to the areas of quality, safety, value, health equity, and addressing disparities, achieving equity. Fundamentally, my pursuit in healthcare comes from a desire to assure that anyone who enters our doors in the healthcare system gets the best we have to offer, no matter who they are or where they're from. Certainly, my lived experience being originally from New York City, more originally from Puerto Rico, gives me a unique window and has given me a unique passion for better understanding how we could meet patients where they are, patients of different backgrounds, of different perspectives, of different cultures, with different levels of trust, different levels of health literacy, of different ages. So that spectrum of difference that really is the essence of being a healthcare provider, really is the essence of understanding that individual in front of you and thinking about ways in which we can leverage systems to achieve high quality, high performance, high value care that is safe, effective, and equitable has been the work of my career to date. Now, I've been able to do this in a couple of different ways. As was mentioned, the Disparities Solutions Center, a center that I founded in 2005. We have had a chance to work with probably over 200 healthcare systems in about 35 states across the country, really trying to get organizations to focus on how to, in fact, identify disparities and achieve equity. And we have found incredible partners across the country who are equally committed to this noble mission, the noble journey of essentially living up to our values. I've had also the good fortune in the last about 2 years or so to take on an executive position here, focusing more of my attention internally at Mass General Hospital, and most recently providing oversight for our equity and community health portfolio of work, where I oversee our diversity, equity, inclusion, and community health work. Team of about 150, a budget of about $25 to $30 million a year deployed so we could live our values, certainly. Now, in reference to today's discussion, I'd say that in March of 2020, I was asked for our parent system, Mass General Brigham, to lead our system's equity and community health COVID response. And so what I'd like to do today is reflect a bit on some lessons from that effort, and then tie them in, weave them in to the work that I've been able to engage in with our Center for Quality and Safety, and particularly work that we've done in the area of patient safety. And so I've entitled my presentation today, COVID-19, Burnout and Patient Safety, Bad for All, but Worse for Some. So what I hope to cover over the time we have together here now is first, some key lessons from the work that we were able to do. It really began with some of the early work of increasing testing in communities, to delivering care kits as a mitigation strategy, really putting out fires in communities, to developing a whole series of strategies and systems to improve the quality of care we were delivering to our COVID positive, particularly vulnerable patients in the hospital, and then finally pivoting to vaccination efforts. So we've really left no stone unturned, but there's no doubt that there have been a series of key lessons that I think should inform us in the quality and safety space and more generally in healthcare going forward, and I'd like to humbly share those with you. I then want to turn my attention to patient safety. And I just want to highlight a couple of key things that are really central principles to me in this space, and then talk about certainly how we have been undoubtedly in the perfect storm over the last few years as it relates to patient safety, and call out and dissect how this perfect storm has been bad for all, but absolutely worse for some, and how we could think about this going forward, equity as a key principle of safety in the road ahead. So let me begin simply by saying that as I think back to January and February of 2020, and the pandemic was impending and we began to hear about it, individuals like me who've been dedicated to the care of vulnerable and underserved populations began to look at history as our guide. And the first and foremost thing that I think compelled us was the fact that history has told us time and time again that man-made and natural disasters disproportionately impact vulnerable populations. We've seen this throughout our history, and so we were anticipating that the COVID-19 pandemic would do the same. We also understood that given a series of contextual factors that we were learning about COVID and that we understood about our communities coming together, that it would pose special challenges and the pandemic would disproportionately impact vulnerable communities. So those included simply the fact that we learned early on that COVID would have a greater impact on those with chronic diseases. My work on health disparities demonstrated and has highlighted over years, incredible research throughout decades, that minorities suffer from greater morbidity and mortality from some of our nation's largest killers, like heart disease, diabetes, asthma, HIV, higher levels of infant mortality. So going into the pandemic, certainly communities of color were at a disadvantage just from the standpoint of potentially getting sicker and having poor health outcomes. If you also began to think about the way the virus spread, certainly quickly in a 10-day asymptomatic period, we began to understand the contextual factors, the social determinants that included individuals who lived in multi-generational housing, individuals who live in densely populated communities, individuals who were dependent on public transportation, essential workers, as being the kind of group of individuals who would likely be hit early and be hit hard. And in fact, that proved to be the case. So around the country, the first real epicenters of the COVID pandemic were in fact in vulnerable communities and communities of color for whom that context was key to their daily life. Those individuals really helped us, many of us, be able to work from home, have our food delivered, have our groceries delivered, be able to socially distance, and as a result paid a huge price early in the pandemic due to their very high infection rates. So this has been a long journey, and ultimately we have understood that minorities have disproportionately suffered the brunt of the pandemic with higher morbidity and mortality rates. Now, I want to share some key lessons here to ground our discussion, again, that I believe are relevant for healthcare in general, but certainly for quality and safety. First, I'd say that these last 2 years have taught us that we need to be more deliberate, given what we know about history and contextual factors of emergency preparedness and impending natural and man-made disasters, to incorporate an equity analysis into emergency preparedness. So what does that mean? That quite simply means understanding the key aspects of the emergency itself, and then determining what populations are living in those contextual situations that put them at higher risk. But being deliberate, not chasing our tail, not doing this in afterthought, will be incredibly important if we are to learn anything from this pandemic. Because, as I mentioned, communities of color were hit early, hit hard, and were in the perfect storm of the set of factors that I mentioned. Lesson 2. We need to incorporate demographic information and equity measurement in all we do, and especially as it relates to situations like pandemics and other disasters, because it is only then that we could engage in the appropriate set of surveillance, monitoring, development of dashboards and reports that could serve as a springboard for action, precise, surgical, and targeted action to those who are at highest risk. This might change, disaster to disaster, but certainly I believe that those demographics, not just race, ethnicity, but many of them, can help us use big data to be more focused as it relates to our interventions. Third, as we redeploy for emergencies, things like having different talents, different skills, not just clinical, but even speaking different languages, can be an incredible asset. Certainly here at Mass General, we were able to identify clinicians, caregivers, nurses who spoke different languages and used language as an asset to redeploy to assure that we were meeting the needs of diverse populations in different areas of our enterprise, whether it be in testing, employees coming into the hospital for attestation of being asymptomatic, all the way through vaccination and bedside services. So just thinking about what are the ways in which we could learn more about our workforce and leverage their skill set to best meet the needs of our patients and our communities is an important and I think deliberate effort that we should be engaging in. Again, our use of multilingual registries, specific care groups, delivering trusted messages and using trusted messengers to do so, really understanding how that diversity writ large is critical to emergency preparedness and certainly pandemic response. Lesson 4, as we evolve clinical care, we need to assure equity. And so a lot of what we did early on and throughout the pandemic was staffing hotlines, providing information, deployment of virtual health, use of our electronic health record. Throughout every one of those instances, we took a bit of a time to discern, is this going to meet the needs of all people? If not, who are we leaving behind? And what are the customized strategies that we need to build in to meet their needs? So hotlines were built in multilingual fashion, patient information, making sure that it was at a low level of health literacy and in different languages. Virtual health, certainly being able to do just telephonic telemedicine, which I had to do with a lot of my patients who were subject to the digital divide. And the use of the electronic health record, where we see in many instances across the country that vulnerable populations are less likely to be enrolled in Patient Gateway, MyChart, and other ways in which we are routinely communicating with our patients. Lesson 5, we need to care for those within our walls, and communication is key. One key thing we learned is that many of the vulnerable populations that we are aiming to care for out in the community are in fact our employees. And they tend to be our employees in lower wage services, materials management, nutrition and food services, environmental services, and getting them timely information both to protect themselves, to protect all of ourselves together in our healthcare institutions, and so that they could be well-informed ambassadors in their community was essential. And so being able to democratize that communication, not just push it out via Zoom, via email, thinking about emergency texting and basically low-tech, high-touch mechanisms have been and were a key lesson for us and something that we implemented across the duration of the pandemic. Next, the social determinants of health will always worsen in the case of disasters. And in this case, in the case of a pandemic of this nature, hasten spread. So we have focused a lot on the social determinants. We've talked a lot about them, but ultimately what we understood was, while we might do a lot to preserve ICU beds, preserve capacity, really an upstream approach and a fundamental doorstep to bedside and back to doorstep approach to addressing the social determinants was going to help us mitigate the impact of COVID. So I share these as key lessons that we are trying to embed into our go-forward functions, certainly trying to make sure we have the courage to do so and to be deliberate as we do that. Now, I want to shift to patient safety because throughout the pandemic, we constantly kept our eye on patient safety. And I would appeal to you that there was a clear intersection between some of these equity issues that I'm raising and some key principles of patient safety that were even further worsened by the perfect storm we faced. So what do we know and what are some basic principles as I think about patient safety? First, we have come an incredible way from to err is human. The Institute of Medicine reported in the early 2000s, some 20 some odd years old, understanding that patient safety is about systems and it is about culture. And individuals operate within systems and culture, but we center systems and culture as key drivers of our patient safety efforts. Nevertheless, we need to understand that the anchor of patient safety are individuals. Individuals who every day need to be attentive to hand hygiene, need to be attentive to prevent never events, need to be attentive to all the things that we've done to support a system and to support a culture of safety. Now, the research tells us a couple of things that I think are particularly relevant to this topic. One, fatigue is a major contributor of safety events. And number two, related to the work I do, disparities in patient safety do exist, have existed, and there's plenty of research to demonstrate that due to communication challenges, trust challenges, language barriers, lack of sense of empowerment, activation, less experience navigating the healthcare system, less comfort speaking up, minorities suffer more medical errors with greater clinical consequences than their white counterparts. And again, there are some provider and operator responsibilities here, stereotyping, issues related to assumptions about patients, a whole series of factors. And we have aimed to try to disentangle these as we build a truly equitable patient safety system. So what happens? The perfect storm really takes shape over the last 2 years that I think exacerbates patient safety for all, but puts particularly vulnerable populations at higher risk. The COVID-19 pandemic certainly taking us to a new level of stress and a new level of need for innovation in the setting of incredible challenges. This leading to incredible burnout that we are still recovering from today and will be recovering from for years to come. Deferred care, an incredible amount of deferred care where now we have seen unprecedented capacity challenges. Our emergency room is a capacity disaster almost every day. We see individuals who are presenting to us with lower levels of screening, again, higher rates, lower levels of screening among vulnerable populations, later complications of conditions that were previously treatable. And these capacity challenges, in addition to these new surges that have hit us, have just created incredible disruption in our care teams, impacting our culture, our climate, and certainly incredibly challenging staffing situations that we've all experienced nationally. So just a couple of weeks ago, we've seen the first, I think, research around the drift that we've had in our patient safety efforts. And I'll say for many of us who've been working very diligently in this space for a long time, you know, it was a bit of like, well, really, we've been trying to keep people alive. We've been trying to keep people just at the bedside. We've been trying to do our best, but the reality is that it should not be a surprise to us that we've seen a drift in patient safety as we have prioritized our survival and the survival of our patients. And so now the opportunity is for us to take a moment to look at where we are, particularly to think about these factors of the perfect storm and consider how this has been challenging us all, but certainly has been worse for some. And I want to call out a couple of these things before I turn us to the road ahead. So when I talked about the impact of the pandemic, yes, COVID-19 has been bad for all, but it has absolutely been worse for some. The major disparities I mentioned being central to this analogy. Second, burnout has been challenging for all of us. But within the context of the last 2 years, we've also had the murder of George Floyd and a major reckoning on racism nationally that has taken a toll, particularly on caregivers of color every single day. We've also had higher incidents of workplace violence from patients. I think a lot of very damaging language to our caregivers. And again, I would say that this has been bad for all, but has been worse specifically for caregivers of color. So when we think about burnout, wellness, well-being, we should understand that there are tiers of people who have suffered more given the context of the last 2 years. Deferred care. So I talked about the impact of deferred care. If you came into the pandemic with disparities and you deferred your care, we will see and are seeing poor outcomes for those who were sicker at onset. Bad for all, worse for some. Capacity challenges, which have impacted all populations, certainly worsen already limited access for vulnerable populations. And the care team disruption, staffing challenges has impacted our level of collegiality, of communication, and this has certainly had an impact on the racial climate and climate for understanding each other in the caregiving space that has a further impact on fatigue, again, that ties to patient safety and patient safety efforts. And then, as I mentioned, the drift in patient safety, we're beginning to see it, and we anticipate, and I pose this as a rhetorical question, that data will show disparities being worse than before. So I was recently asked in an interview about all of these things and how they all come together. And there is no silver bullet. We are still dealing in parts of our country with the latest surge. Burnout, again, is going to be something that is with us, not just in the short term, but the long term. We will be dealing with COVID long haul, deferred care. Hopefully the capacity challenges will improve. The care team disruptions and staffing challenges are still a ways off from being addressed. And so what do we do? What did we do to preserve patient safety in a very stressed time? And the answer is we did the best we could. And some of those key principles that we brought forth during our most stressed times, I believe are the same principles that we need to look back to drive us in the road ahead. I'd say first and foremost among those is a sense of kinship and connectedness. As I served on our surge teams, as we provided care in multiple settings to individuals with COVID, both here in the hospital and the community, the single biggest inspiration was my colleagues. My colleagues, not just our doctors and nurses, but everybody across the care team, from individuals who clean the rooms to our respiratory techs, that sense of all being in it together, holding each other up, that sense of kinship and connectedness allowed us to say, let's keep everything as forward as we can, as together as we can. And that included in the area of patient safety, keeping ourselves honest, lifting each other up, reminding ourselves of kind of protocols and guidelines. And I believe that kinship and connectedness will drive us forward on the road ahead. I'd say second, we were able to and tried to focus on our own recovery and healing, going from being dealing with one death in an ICU, once every 3 days or once a week to 3 to 6 deaths a day. That recovery, that healing, that moral and emotional distress certainly lowers one's radar around things that seem more trivial, like some of the important safety efforts that we engage in every day, like hand hygiene and other areas. So I believe that the road ahead will need to be built on principles of recovery and healing. I would urge us all to think about the factors that I brought forward here and to consider what special attention we might need to turn towards as we think about those disproportionately impacted by the pandemic and as research I'm sure will demonstrate by patient safety events. So incorporating that equity discernment into everything we do will be essential and will be critical to patient safety for all. Finally, I do believe it will be incredibly important for us to reestablish and reinforce our safety culture and values and our culture of values more generally, and pivoting from survival, where a triaging of those things that seem less important to us in the moment now become central to who we are, part of our renaissance and rebirth, will be, again, key elements of the road ahead as we think about patient safety. Bad for all, worse for some, but I'm hopeful and optimistic of our future. And I really hope that some of these lessons can be embedded in the quality and safety work as we move forward, and certainly in the emergency preparedness work in our future. So with that, I thank you so much for your time. Happy to take some questions and engage you in discussion, and appreciate being back here with BAHHA. I've had the good opportunity to share thoughts with this group over the years. And so I'm incredibly thankful and appreciate everyone's time. Thank you.
Well, we do have time for 1 or 2 questions. I want to thank you for that, Joe. I'm glad you're optimistic because you're saying bad for all, worse for some. So a little worried there, but a good point that was brought up is, essentially what measures do you use to evaluate whether there are health disparities in your health system? And someone referenced, looking at data about readmission, looking about mortality, and not seeing a difference. So it's a 2-part question that I'm going to modify it a little. Is that realistic that a health system doesn't see any differences?
Yeah, so I'd say 2 things. I'd say one point just that's of interest is this year is the 20th anniversary of the Institute of Medicine report, Unequal Treatment. I had the great pleasure of being on the study committee that released that report, where 20 years ago we said, disparities in healthcare do exist. They exist in different settings. And this isn't about any one suspect or solution. We should get about the business of better identifying and addressing these differences because they are multifactorial. This isn't about good or bad people. This is about systems that aren't particularly constructed to meet the needs of diverse patient populations. So that reality, I think, compels us to say we do need to be attentive. Disparities do exist. And I would say in the last 20 years, we've seen incredible progress in this space. So I'll give us, John, as an example. Since 2007, well, since in the early 2000s, we've been collecting key elements of patient demographics on registration: race, ethnicity, language, highest level of education. Obviously, we have payer status. And we built out in 2007 something called our Disparities Dashboard, where we fundamentally stratify all of our quality measures, ones that we pull off the shelf, by these different demographic characteristics to truly and with certainty be able to say whether or not we were delivering equitable care. So, for example, we did look at HEDIS outpatient measures, readmission rates, all of our core measures, and hospital quality core measures. So, and over the years, we've built additional measures on top of that. So it is absolutely possible. If any of you are interested, this report now has grown to upwards of 50 pages. And we've worked with organizations across the country who've built these great reports out. Sutter Health being another great example. You all could Google Mass General Hospital Annual Report on Equity and Healthcare Quality. We went public with that report in 2014. So you could see all of our measures. And yes, we did find disparities. It's not a bad thing. It's in the spirit of quality improvement.
And we would expect to see disparities given where we are with healthcare system. But what's different now, Joe? We've had different periods of time where we've had a renewed interest and a focus on issue of disparities. Now we're also using a little bit of difference of nomenclature. We're saying equity, right? Do we have the commitment now to make these changes? And do we have the resources as well in order to establish these benchmarks to address solutions? I mean, we're talking about, physicians talking about food insecurity with patients. And what's different now? Is it the COVID pandemic that has shined a light on it?
Yeah, absolutely. So I'd say, we can't afford not to be attentive to equity if we are focused on quality. And ultimately, I think the Institute of Medicine report, Cross Inequality Chasm, really centered equity as one of the 6 key principles. So we hope that conversation has been had. Now, to your question, what can be done and how has that conversation changed? I think we have a lot of organizations that prior to the last 2 years have been committed to this, have invested resources. Mm-hmm. And in fact, we've had a chance to work with hospital associations. I'll call one out in particular, the South Carolina Hospital Association. Several years back, the South Carolina Hospital Association, using their all-payer database, was able to give report cards to all their hospitals showing readmission rates and showing the black-white difference and demonstrating the return on investment if they eliminated that gap, and really giving those hospitals both a view to their data and, number 2, the ability to think about, okay, these particular interventions are going to help us address that gap and have an ROI as we think about our readmission penalties. So there have been creative strategies in that space. Okay. And certainly I believe those sets of interventions are going to be important. Now, to end here, I'd say that yes, the last 2 years, the pandemic and these inflection points in our history, these reckonings that we have, particularly over the last 2 years, our reckoning on racism and a greater focus on equity, has absolutely re-energized this space, and we're seeing unprecedented action now.
Joe, the questions come up, has the pandemic just uncovered these issues of disparity, which you and I and others have known about for a long time, but maybe others did not, or has it actually exacerbated disparity?
I'd say both, John. I'd say both. I think, as I mentioned early on, we anticipated this going in, so we anticipated they would be uncovered. It would kind of lay it bare. And I would say now, as the dust settles, it is worsened. When I highlighted deferred care, we will see broader disparities there in those individuals who deferred care if they were sicker when the pandemic started. We already know the disproportionate morbidity and mortality of the pandemic on communities of color. So it's a both and, unfortunately, but I'm hopeful that we can now take action.
Last question then. What are we going to talk about a year from now in terms of these issues?
Yeah, my hope is that, what I've always said is that this is a stepwise process, not unlike safety, where you have to build the buy-in and secure leadership commitment, but you cannot manage what you don't measure. And so it does need to begin with effective data collection, performance measurement, and then interventions. So my hope is that next year, the conversations we can have are X amount of hospitals are collecting data. They've used measurement tools, routine measurement tools to stratify They've identified disparities, and hopefully next year we could say that some interventions have begun to narrow some of those gaps. That's ambitious,
Okay.
but I think it's possible, and that's where we should be headed.
Does it have to be backed by payment policy?
Absolutely. I think that, I'm a big believer in not just sticks, but carrots. And I think we do see many payers being more thoughtful here in this space. And so I was very bullish, John, when we were kind of having conversations around our drive towards value. And I did believe that, and we were seeing investments by healthcare systems when you're on the hook for a population of diabetics that weren't just about the right meds, but about, addressing food insecurity issues, the deployment of healthcare coaches or navigators or community health workers, right, to address population health. I do think we can continue to build on that. The evolution of value-based contracting will be helpful, but I do think that payers will engage, hopefully, in some more strategic measures to hold us accountable for delivering high-quality care for all of their members, not just a select few. And I would say certainly on the government payer side, we're seeing more rigor coming out of that space also.
I keep saying last question. I throw one more in, but I'm just going to throw in one more. It comes in. It says, have you looked at how to integrate patient demographics into the event reporting system to understand the connection between event reports, including near-miss events, with various patient groups?
We have, absolutely. So we use RL Solutions here as our event monitoring and reporting mechanism. And we've built in some opportunities there in a box so that you could identify if it's a disparities related issue. But we've also tried to build a culture of reporting when language has been a factor or some other factor that we might consider, kind of root causes to these disparities into our reporting system. And then being able to stratify them is something that we're focusing on. So absolutely. And I'd say over the last year, we've been able to dissect several of those that are helping us improve what we're doing in the area of safety.
Well, we truly have run out of time. I know folks have to head out to some breakout sessions, but Joe, I want to thank you for all that you're doing, for raising awareness. And, we just can't preach to the choir. In many ways, we have to reach those groups who are struggling with these challenges or maybe don't recognize the full extent to the challenge. So collecting the data is the first part, and then thinking of new and creative solutions to address it. So I want to thank everyone for participating and look forward to the breakout sessions.
Great. Thank you so much.